Thank you everyone for getting up early this morning. Hope everyone's enjoying the AACC so far. My name is Randy Schneider. I work for Abbott Diagnostics in scientific leadership, global scientific leadership, that is. I'll be moderating the workshop today. This workshop is part of a series of Abbott-sponsored workshops that are highlighting a broader theme of promoting healthy hospitals, laboratories, and healthcare systems. Before I introduce our distinguished speakers this morning, just a couple things I want to highlight. First of all, it's important for us to get the evaluation, so if you could please spend some time when you leave to fill those out, we'd appreciate it. Another thing on the table, you'll see some table tents for a blood drive tomorrow. We're also sort of reiterating the importance of this blood drive. The American Red Cross is here. It's at from 8 to 1 p.m. In the Philadelphia Marriott downtown, so this facility. Fourth floor, Franklin 13. I don't know what Franklin 13 means, but it must be a large room. So if you can do that, that would be great. We're supporting that. Okay, so let's get to it. Our two speakers today are both from Seattle Children's Hospital and the University of Washington. Dr. Mike Astian is a clinical pathologist and professor of pathology at the University of Washington. Jane Dickinson is a clinical chemist, also from Children's Hospital. She's a clinical assistant professor at the University of Washington. So I'd like to introduce Mike first to speak, and then I'll have Jane come up and speak after. We'll try to do some questions and answers in between if we have time. If not, we'll hold those till the very end. Come on up, Mike.
Thanks. It's good to be here. You're all sitting at the back, so I'll resort to screaming. But thanks for getting out early. And Jane and I do a lot of work together. She's my second best friend at work, and I think we have complementary styles, and we're going to cover different material. I'll talk till about 8:05. Hopefully, I'll have some time for questions, and then Dr. Dickerson will come up. And I'm going to talk. We're going to talk today about a national local interventions to improve the utilization of lab tests. Lab utilization management is a hot topic. It's a trend, not a fad. And we have to disclose our finances. So we have some intellectual property with the insurance industry that helps with lab claims rules. And then we have educational software with a company that we spun out of the University of Washington called Medical Training Solutions. We're here today representing Seattle Children's. We're not here as individuals. We're representing our employer, and it's a great employer. It's a great place. Obviously, we have a lot of people to thank, but I really want to thank Abbott for hosting us and sponsoring us. And all our colleagues. This work that Jane and I are talking about today is a real symphony of collaboration with our many collaborators. So I'll start. So I'm going to talk first about utilization management, a little bit about value in lab testing and why genetics is different. What is the motivation to improve utilization? Obviously, there's a financial motivation, but the real motivation is to improve outcomes for patients, get them the right test. I'll talk to you a little about some of the disasters we see when looking at insurance claims. You know, everybody says, the insurance companies, they're horrible, they're, devils incarnate, But in fact, I'll show you some abuses that are fairly interesting, the data. Then we'll talk about general interventions to improve test ordering. Dr. Dickerson will get pretty specific and show you some great examples. And then we'll talk about this network that we decided to quarterback after a lot of hospitals were kvetching about send out tests. And everybody knows kvetching. Most of you are Yiddish, so I assume I can use a lot of derogatory Yiddish terms. But they were kvetching about the send out bill, and doctors don't know what tests they're ordering. And so we formed a very grassroots organization called PLUGS, Pediatric Lab Utilization Guidance Service, which quickly became popular and then became more than pediatrics. So what is utilization management? What does it seek to eliminate? The first thing it seeks to eliminate are all the old tests, where you're mouth pipetting and standing knee-deep in benzene like the old days and looking and tasting urine. All those things are out in utilization management. You can't taste the urine anymore because it's obsolete. Also, tests that are not tests, that would be any, like an IgG allergy test. Tests not ready for prime time. These are things that could be tests, but they're put online too quickly. Over-bundling of gigantic tests where you get a $500 panel when you need a $20 lipid panel. It gives you all the information you need. Quackery, that's most of the wellness movement. The irony of the wellness movement is it makes everybody sick. And so that's the idea that you're going to have look for all these nutrient, mineral problems and all these things that you don't have and allergies you don't have. Tests that are always positive. So there's a whole bunch of labs out there from Lyme disease through nutrition where if you send it, they send you back a positive. That's a form of quackery. So utilization management stands against that. We have a lot of patients now who demand to be positive for Lyme disease. They send it to labs. But if you want a positive, if you want Lyme disease, you can get it. And in fact, if you want anything, if you want to take yourself out of the game, there's a lab that will take you out of the game and make you sick. And restrict your eating and all that kind of stuff. So we stand against that. Any lack of active control in genetic testing and utilization management also seeks to help doctors to retrieve the tests. About 5% of tests in the United States go unretrieved. It's one of the biggest, one of the top 3 sources of litigation and patient harm in the industry is not retrieving a test that turns out to be important. We want to improve lab utilization to improve value. Value is your patient. Is the quality of what you get divided by the cost of what you pay out of pocket. If you can't pay out of pocket because you're impoverished, then all the other patients pay, right? We transfer the costs onto commercial insurance or we raise the prices. That's value. So we seek to protect patients from unnecessary costs. This has become a big deal in the era of genetic testing where tests instead of costing $30, $50, $100 can be $5,000. And lab utilization also seeks to decrease false positive results that result from testing in the low pretest probability setting. You know, what's the test for headache? There is none. There's no test for headache. There's probably, I mean, if you're not having a heart attack, there's no test for chest pain, really. I mean, if you're just like having your regular, I just had a big meal, I drink and eat too much, chest pain, there's no test. There's no test for your TMJ pain. There's no test for that. Your hair's falling out. Probably no test for that. There's no test really for the symptoms of daily living. You're a little wet. You're a little dry. You're a little anxious. You're a little angry. I got no test for you. Testing is mostly for sick people. Wellness is mostly mythical. And there's some good screening tests in the wellness movement, but we've never had more tests available, and there's never been fewer tests recommended in the era of evidence-based medicine. That's just the truth. So you can look at the U.S. Preventive Service Task Force or any evidence-based guidelines for screening tests in asymptomatic or mildly symptomatic people, and there's not that many tests to have. So there's competing healthcare trends influencing test utilization management. And this is a lot of this is driven by capitation. So if you're just getting paid the same amount per patient, then we're now motivated as labs to do more testing. It's certainly a rule of life that less is more. Less testing, a few tests well chosen is good, or there's certainly a number of tests that's enough testing. More is not better. More is really not better for anything. I can't think of one thing where more is better. You know, 1 piece of pie is good, 2 is all right sometimes, 3 is sickening, 4 is torture. And that's how lab testing is. We're not going to be running 300 tests on people and doing personal reference ranges and stuff. That's just not going to happen. That could happen with some individuals. In fact, it's going to happen like 100 years from now. Just like it's easy to say we're going to do 1,000 tests on everybody when they come in the hospital and do big data, and it's going to be great. But that's magic. I don't run a magic lab. I run a regular lab. Regular lab. Few well-chosen tests, well-executed, fast, at a decent price. That's what I'm talking about. Other trends that influence utilization management are the Googlification of everything. Google allows you to quickly misinform yourself, and then social networking allows you to advertise that to other people, so your friends are also getting tests that they don't need, so you can do it together. A big trend is molecular testing, both for cancer genomic profiling and for inherited diseases. And this worries insurance companies because the overall lab industry is growing by about 6 to 7% a year, but molecular testing is growing 15 to 22%, and those tests are expensive. They're often out of network. Single biggest complaint we get in the lab is related to pricing, not quality, not turnaround time. And the last trend is that everybody's increasing the management of lab testing, both inside of hospitals, probably a lot of you are here for that, and then insurance companies are now starting to look at lab testing like they do radiology, cancer drugs, and other areas of medicine, and they're actively managing not just the price list, but doing pre-auth on expensive tests and things like that. This is an example of non-standard tests. I could show you 4 slides on this. You know, there's a bunch of rules of thumb I can give you, but if, a good example is if you're testing hair and it's not arsenic, there's a 99% chance it's quackery. If you heard the word dysbiosis, there's a good chance it's quackery. Anything alternative. Anybody who tells you you're inside the box, you're testing inside the box, and they're outside the box, you're not thinking outside the box. I get accused of I'm not thinking outside the box. And what I say is, well, if I send a test to you and it's always positive, I may not be thinking outside the box, but you're not thinking at all. See, I'm practicing medicine and you're practicing magic. Magic. It's always positive. What the hell kind of testing is that? And we're making people sick. So overutilization is gaining increased attention. Choosing wisely, plugs, our thing, Pediatric Lab Utilization Guidance Services, increased number of publications. There's a lot of utilization meetings now. There's a whole overdiagnosis meeting. You can go to. I'm sure a lot of you know people who've overdiagnosed themselves. In general, when you're middle-aged, you're not going to feel great, but you can feel pretty good. But as I like to tell my kids, don't get too involved with your symptoms. Like if you have a grapefruit-sized tumor, growing outside of like your bone or something, or blood's going on the ground, or you like drop an arm onto the floor, you should be pretty worried. And we'll probably have a good lab test for you. You got cancer, you need a transplant. Lab testing will save your life. It's really important. But if you just have the symptoms of daily living, you got a little backache, your in-laws are in town, so inevitably you have some diarrhea, there's no testing for you. You got to just suck it up. You're resilient. You're a resilient person. You can do it without lab testing. Once you're sick, you need it. So we talked some about the root cause of utilization, the more is better mentality, Google, fee-for-service medicine, et cetera. I'm going to show you some data now from some gigantic databases. This is some older data, but we actually recently repeated this on very new large claims databases. So these are based on insurance claims. This is our work with Evicor. I'm going to show you data from 3.5 million people over a year who had 8.2 million doctor's visits. The big picture is we found 10 areas of abuse. 10 areas of abuse where there is generally over-testing. And in the last 10 years, only one new domain has been added, and that's pain medicine. So the idea of pain medicine is these mills where I'm taking an opioid, so I'm going to pee in a cup every week, and I'm going to take a larger and larger bill for a larger and larger panel and unbundle it. And instead of paying $200, which is more about what you should spend, or maybe less, a lot of labs we see in the insurance claim have come up with schemes to build $1,500 a pop and test people every single month. Wellness, just overly concerned about yourself, so you measure 500 allergens instead of the 8 you need, or maybe you don't need any. Overbundling and cardiovascular disease risk. Women's health usually focuses on unnecessary molecular diagnostics and infectious disease and for cervicitis vaginitis. Nutrition and metals. You don't need to measure your molybdenum level or your bismuth level at all, or beryllium, unless you work in like an atomic munitions factory and you didn't put on your garb. You're probably not a downwinder. Being a downwinder from a chemical factory is a real thing, and most of you are not downwinders. Some people are, and they need that kind of advanced testing. There's no reason to measure your cadmium. There's no selenium deficiencies in the United States unless you're missing your gut. You have your gut removed, you need a selenium level. But you don't need to measure selenium. You probably don't even need to supplement, but if you supplement with selenium, you're okay with me. Just take the supplement, don't measure the test. Allergy testing, flow cytometry is overbundling, autoantibodies is overbundling, inpatient daily labs, which my colleague Jeff Baird has done quite a bit about. Dr. Dickerson's done a lot with Patrick Mathias at our place. Stable inpatients do not need daily testing. And then, of course, we'll talk about genetic testing, which is misordered 1/3 of the time in the United States, and there's a lot of data, ours, Cleveland Clinic's, ARUP's. So I'll show you a few examples of these. So we looked at 3.5 million people for women's health issues, and there was 82,400 visits a year for cervicitis vaginitis, and not recommended tests were done in 22% of the visits and increased the bill by quite a bit, 1.4 million in this database. Probably increases the national bill about 5 to 7% in this area of testing. Here's allergy testing. I think you'll find this interesting. The test you need if you have an allergy is IgE, allergen-specific IgE. Like maybe you have like a peanut allergy. It's a real allergy, life-threatening. It's a real thing. So you need an allergy test for that. The test you don't need ever is an IgG allergy test. It's very popular with naturopaths. And then there's a whole bunch of tests that aren't tests, including the ALCAT test and a bunch of other stuff and weird in here. Now, all the weird stuff, the quackery adds about 4.4% to the national bill. This was about 19,000 visits in that year from that database. But what's more interesting is the overuse of tests that could be useful if they were bundled properly. So if you look over here, 1 to 10 units is about what you need on any allergy workup. Like if you think you've been exposed to a venom, or you have an inhalational allergy, or you have a food allergy, usually you need 10 units or less. That's your panel. Now, we can tolerate up to 20, that's fine. But you can see that about 54% of the workup are greater than 21 units, and 7% in the United States, 7% of the workups are above 40 units of allergens, and those people we were making sick. Because the chance of a positive allergy test once you're testing more than 40 is extremely high. The chance of having a positive allergy when you test 500 allergens, you're going to have an allergy, but it's probably not causing your symptoms. And then what do? You start to restrict yourself. And you know these people. You can't go out to dinner with them. They're pointing out what you're eating. You eat that. That gives me hives. And you're like, I'm not interested in ever dining with you again. I'm trying to enjoy myself. You see, you know these people. You don't even want them in your home. They're telling you to eat a bag of tasteless snacks. You're like, I'd like to have some birthday cake. Life is short. I'm not planning on living forever. I just want a slice of cake. Can you just be quiet? Nonstandard cardiovascular disease risk test, bundling $500 tests when a $50 test is needed. In the vast majority of cases. More than 95% of people being screened for cardiovascular disease risk just need Framingham-type risk factors and a few tests. This adds, I think in the next slide I show you that this was one database from 1 year, a couple of states. Total spend was $561 when these labs were involved. When you need at most a $50 experience. This added 13% to the bill for that insurance company, of which nearly all of that was unnecessary. Who pays for that? You do. You do that. It's in your copay. It's in you pay a certain, you or your employer pay a certain amount per member per month, right? That's what we say, per member per month to the insurance company. You pay for that. You pay for that. It's built in. All this unnecessary testing, 13% here, 6% there, 20% there. You pay for it. So what are insurers doing to reduce lab payments? They use two methods. One is medical necessity rules. They say, look, it's not necessary to have a 500 allergen panel or a 30 autoantibody panel for a lupus workup. 8 antibodies, 13 antibodies will do. So they make medical necessity rules, or they say these are the inclusion criteria for having this genetic test. If you want to do an exome, these are the reasons. Or they make up administrative rules, like here's your fee sheet. This is what you're paying you. You bill us 500, we give you 50. That's an administrative rule. Or they create lab networks so they can get discounts. The documentation rules, co-payments. Those are administrative rules. That's how they do it. There's a lot of companies now insurance companies do this, and then there's a whole secondary industry behind the insurance companies to service them with lab products. There's a lot out there. The one you probably heard most about is Beacon, which also tends to funnel tests over to LabCorp as well. So let's look at the general classes of interventions to improve laboratory tests, and then Dr. Dickerson will give a lot of specific examples. This is nothing I'm going to talk about is hard to understand. It's really about having the backbone to have a crucial conversation. Some pathologists are capable of doing this, a bunch of clinical chemists are, and a lot of people aren't, and so you've got to send the people who can. You have to have a little bit of charm and quite a bit of backbone. We use a lot of genetic counselors quite a bit, laboratory genetic counselors, and they have a counseling skill set so they can have crucial conversations with people. That's a picture of me as drawn by my daughter, Amy. I think it's a beautiful likeness. I drink a lot of coffee, so it takes energy to do this work. Many systems have done it now and published on it. I list some of them, and I'll show you some of the things they do. They focus on the physician or orderer. Now, in your state, who can order a test depends. Some places you got to have a license and have gone to school, studied in a basement for many years, worked hard, paid tuition. Others, you can declare yourself a witch doctor or a shaman of some sort and just start ordering tests. And in a lot of states, you can just order a test on yourself. But we focus on whatever state you're in, we focus on the caregiver, which is usually an MD, an RN, a nurse practitioner, PA. And the things you want to avoid when you do interventions are telling people to do a better job or just distributing training materials. If you want to get a person to stop ordering a bleeding time or a T3 resin uptake or an IgG allergy panel, take it off the menu. See what I'm saying? That's pretty strong. Don't say, hey, you shouldn't order it. Here's 22 papers and you're an idiot. You don't want to do that. People want to be told nice things. People want to be, so point to good behavior. Say, hey, that guy over there orders this modern test. Stop tasting the urine. And so training is necessary, but it's not sufficient. These are the interventions from gentle to strong. I want to talk a little bit about the strong ones and what they mean. Privileging means only you, Mr. or Mrs. Dr. GI doctor, can order the advanced celiac panel. The rest of you get a 2-test celiac panel maximum. You get an IgA and you get a tissue transglutaminase. That's what you're privileged to do. If you're a family practitioner, you're not privileged to order the spinocerebellar ataxia panel for $4,000 for your 99-year-old patient with numbness in their index finger. You follow me? That's privileging. Send-outs formulary is what you can and can't order. Don't send to the quack labs. Ban them. Under CLIA, the medical director is allowed to choose the labs. Ban the labs you don't want to see. When people ask you to send there, you say, I wish I could send it there. You can send it there, just not from this facility. It's like a restaurant. Let's say we're like a Chinese restaurant, but you're ordering Italian food. Go out, enjoy some Italian food, just not at Seattle Children's Hospital. That's the formulary. Forbidding tests is strong. Teaching people about tests that are forbidden is weak. So you just say, these are banned. This is our policy. Using policy and procedure. You can't, from some of the labs I mentioned, you can't, if a person comes in with a kit to our lab and demands that we send to a lab, we just hand them a policy that we don't do that. It's very helpful. And then my favorite is requirement for higher level collaboration. You order a genetic test at Seattle Children's Hospital, we send you a friend, not to criticize you and tell you you don't know what you're doing. It's like, I'm here to help, and we're going to learn together. And then this is what we do for all our genetic testing. We use a lab genetic counselor. The medium stuff is creating good CPOE templates, with just the things they need. Make it really hard to order stuff that they should, that you should. To order that spinocerebellar ataxia panel, what would a family practitioner have to do? They should have to hit 92 different keys, elbow on the F1, back flip, call me, I'm not in, that's how they have to get that panel. So you make it hard, and then you make it super easy to order the things they need. You make it easy to turn off standing orders, you make it hard to turn them on. So those are medium things. Hard and soft stops. We had a beautiful talk by Gary Prokop from Cleveland Clinic about how they use hard and soft stops to get physicians to pause. Do physicians like to be stopped in the electronic medical record? No, they don't. So you want to be sympathetic, empathetic, and cautious. Physicians, it's not easy to practice. Where I work, it's not easy to practice. When I was at the university, it's not easy to practice. So you got to partner with them, use those stops, use privileging in a way that's empathetic to help them come across as helpful, not critical, with the exception of quackery, which you have to block. And then the gentle stuff is like reminders that they can override, or training and things like that. I like training for social reasons. Like, it's good to have a training that these tests are now banned and why. That's a good training. You have to structuralize things in utilization management. You have to make it structural, that it's easy to order the right thing, or you're forced to order the right thing. And physicians tend to like that. The way we like to influence physicians' behavior is to treat people nicely. Physicians don't like hard stops a lot. They don't like soft stops. They like when the template in computerized physician order entry makes it easy to order. They like a report card if it's not punitive. Like, it's better to say, like, I had a report card when I was in 4th grade that says Michael misbehaves in school and talks too much. That felt bad. My mother punished me. But if that report card said something like, Michael could behave better in the class, he has a lot of potential to behave better in class, and here's some specific things he could do to be quiet, that would be a little bit, you could package that better for me. So Brian Jackson wrote this article about nudging, which is, instead of saying you're ordering the wrong test, you don't know what you're doing, you say, hey, look at that guy, he's ordering the right test. Have a meeting where you say, look at this great behavior by this physician with their celiac panel, or with their genetic test ordering. Let's all be like this person. And that's a good way. People like that. That's called nudging. And so that's how we try to influence physician behavior. This is examples of stopping or recommendations that come up. Would you like to discontinue your standing order? Make it easy to turn it off. They start testing all kinds of weird thyroid stuff, reverse T3s, upside down T4s, obsolete T something or another's. You just send a little note, hey, how about just ordering one thing, you know? And then I have that other one. That's not a real message. That's just one I always wanted to do. Changes to manual requisitions. Some of you are still on paper for your outreach or something. The key thing is to modernize your requisition, make it easier to order the wrong thing, and you got to destroy all the old requisitions. You got to find a way. They'll stash them. Doctors will stash their favorite requisitions with those old tests. We'll get a requisition from 2000, 1990. We know who you are. We got to get up there. You got to destroy those requisitions. Don't make a request to bring those requisitions back when those doctors hide them. Go up there with a baseball bat. Tell them you mean business. Hand over your recs, man. Hand them over. You can't order that anymore. Stop tasting the urine. You got to obsolete those old tests. I show a few here. Bleeding time, resin uptake, single-stranded DNA. I talked a little bit about CPOE templates. This is some work from Jeff Baird to show structuralization of a intervention. So this is ionized calciums over time, and you can see 2 hospitals in the system, and during the period from January to March, the tally's not changing, but education's taking place. Coffee's being ordered, donuts, conference rooms, doctors talking, you're great, how you been? You're a great doctor, I'm a great doctor, nothing. Don't order ionized calcium, nothing. Then they changed the definition of an ionized calcium in the system to a total calcium. That's structural. And you only get an ionized calcium if you're out of bounds, if your total calcium's out of bounds, with the exception of a few people who are privileged to order ionized calcium. And look at the structural change that they got. That's a big drop in ionized calcium. And then there was a concomitant change in calcium gluconate unnecessary calcium gluconate orders from the pharmacy, so they even saved a little money. They've shown this now for a lot of different analytes. I'll talk a little bit about our approach to utilization. We have a committee with a bunch of counselors and doctoral level chemists, pathologists, et cetera. And we record all our cases that we review in the database, and we have criteria for reviewing cases, for giving help. We emphasize send-out tests because send-out tests are the highest risk. They're the least understood. They're the most expensive, and they're most poorly reimbursed. It's a tremendous patient safety issue. Dr. Dickerson has published a clinical laboratory news article about 10 things you can do to improve send-out testing. Obviously, committees are going to review policies and procedures, look at individual difficult cases, make subcommittees. We have an exome subcommittee. It meets monthly to look at exome cases and whether they should be sent out for their $6,000 bill. We have a new committee forming around cancer genomic profiling, which is sometimes useful and sometimes not. This is actually a slightly old slide because we review all genetic tests now. We review any request to send it to a lab which isn't the lab we've chosen. Especially, we don't allow patient-directed testing. We're patient-centered, but we're not patient-directed. I think everybody knows the difference. If you want to be your own doctor, you have to practice from home. You got to practice from home. Once you come into our place, we partner with you. But you can't direct your own care. Any request for a test that is off the list or tests that are frequently misordered and we've labeled as under management in the information system, like a reverse T3 would be an example of that. These are some examples of banned tests. I mentioned autism and fibromyalgia. It is a shame that some of our most suffering patients are preyed upon because they have illnesses that are difficult to characterize, broader in spectrum, painful or difficult to deal with socially in the home, and they get preyed upon with the fixed false belief that these things are caused by fungi or metals or things like that, and they end up having a lot of money taken from them. Our experience, we go to this national meeting, Children's Hospital Association, and everybody was having the same problem. The genetic send-out bill at children's hospitals, it was nothing to have $2-3 million of genetic send-outs. Tests were frequently misordered, especially by non-geneticists. So we put together a system, and in our place and other places, we're starting to stand up systems at the same time. So we thought, okay, let's get together and share things. And utilization management is beautiful because competitors will share tricks because it tips, tricks, policies, and procedures because it's for the good of all. And so we created this pediatric lab utilization guidance service whose mission it is to reduce expense and increase the likelihood of ordering the right test, retrieving it, and interpreting it correctly. And this thing just grew like wildfire. It's only been out there for a couple or 3 years, and we're helping a lot of hospitals. The network is helping hospitals stand up these systems that are like ours, or some of them are even better. And actually, this says 54 members and counting, but I think we're actually at 59. Am I right, Natasha? My colleague Natasha Kumar is here from Seattle Children's. She's our business developer. So we're at 60, and look at that list of names. You can see we have a lot of sponsorship. ARUP and Mayo are sponsors, Prevention Genetics, Invitae, Claritas Genomics, which is Boston Children's. Quest is in there. So it's where people who maybe not even the elite children's hospitals are in there, big health systems like Intermountain, joined right away, and everybody's sharing. And they pay a membership fee. And we have a big meeting. We just had our big meeting in Seattle. More than 200 people showed up to share tips, tricks, policies, procedures, give short talks. It's really been nice. We have member meetings where people share what's happening in their place and try to share how they've overcome difficult situations and how they talk to doctors. How did they get doctors? How'd they nudge them to change their practice? So that's what we provide: tips, tricks, policies, procedures, member meetings, Plug Summit. It's been one of the most gratifying. I've had a really wonderful career. This is a nice living, I think. I don't know how you feel about the laboratory industry. You probably come from all over it. I happen to think it's the last dignified industry. It's a job. You can get benefits. There's a lot of times you go out for a nice lunch. I thought the spread here today was lovely. Fruit, I think I got younger. I had like blueberries, strawberries. I think I'm actually growing back the hair. But this, of all the things, this is one of my favorite things. The teamwork, the lack of acrimony, the patient focus, getting them the right test. The biggest complaint I get as a medical director is our client services collect complaints, and the biggest set of complaints, and then we get complaints, turnaround time, we get complaints, billing. Billing's number one complaint. Billing is the number one complaint. Out of pocket. $5,000 test, genetics, out of network, wrong test. You got to pay the whole bill. You're making some of these families, let's say they're making $60,000 a year as a family. That's no Christmas right there. That's no bike. It's big. And we've already saved over $1 million just in our practice over a couple of years, and some of our members too. And that's the people's money. That's the people's money that you're saving, and that's really gratifying. We talked about our summit, which I hope you'll come to next year. And our goals for the network is to essentially increase the quality of utilization management through research, clinical service, and education. This year, we're hoping to influence national policy by grouping the members together to make policies for exome, for other areas. We're doing some stuff in mitochondrial testing, and then to try to push it with insurance companies, which have also started joining the plugs movement and have attended to get these patients covered. Who are these patients? It's me and you. I'm sure most of you have had some out-of-pocket expense that you found shocking. I know I have, either yourself or a member of your family. And so that's what this is. So in conclusion, before I bring up my colleague, Dr. Dickerson, lab test utilization is a trend, not a fad. In general, less is more. In general, not always. There is underutilization. There's a lot of diabetics who need to be screened, but there's a lot of testing that's just unnecessary or wrongly chosen. Most testing will be actively managed by insurers over the next 10 years. Structural, you got to think structural. Make it easy to do the right thing. Don't just criticize people. It's very satisfying to tell people that they're not as smart as you. It feels good. But you don't want to do that. You want to come along as a friend. I have a rule when someone comes into my office. I like that they leave the office a little bit lighter. I like to give them a quip. Poke a little fun at myself, or, make them feel a little. Why should they come into my office and feel like crap? I mean, I'm not going to give them what they want, so I might, because I'm the boss. So I can't give you what you want because there's only so much I could do, and I'm tired. But I can make you feel a little better about yourself. And that's what we try to do with utilization management. Is to help you. Jane's going to show you the response to some of these interventions because she's designed them well, and people feel better about what we're doing. We don't make them feel bad. And then this whole plugs thing has been very gratifying because it's a grassroots movement of like-minded people who want to help patients. So that's all I have to say today. I want to thank Randy from Abbott and the whole Abbott gang for having us out. And I have a few minutes for questions if you'd like to ask one from the microphone before Dr. Dickerson comes up. And then I'll stay after with my pal Jane. We can answer some questions later. Yeah.
Shahangian from CDC. There was a review meta-analysis a few years ago by Dr. Anand Digi that was published in PLOS ONE that clearly showed that underutilization is not only understudied, but also appears to contribute to a greater degree of adverse health outcomes, and is a bigger problem.
Yeah.
Now we know that if we don't have the data, we can measure it, we cannot intervene.
Yeah.
And utilization management has been typically equated to overutilization management.
Well,
the question, my question is, within your institution, what are you and your colleagues doing in order to improve the deficiency
Yeah.
of testing.
So for both underutilization and overutilization, we try to wire in rules, especially in the University of Washington, regarding how frequently you need certain tests once you have a certain diagnosis, so that you're getting microalbumin and A1Cs, for example, in diabetes, that your viral monitoring for your transplant isn't missed through the use of reminders. And these things come up when patients come into the office through the e-care. Through these electronic means, the doctors can see all the things they're due for, and this decreases underutilization. The other way underutilization is also wrapped up in the problem of access. So trying to remind people and engage them in their own health care so that they don't miss appointments. That's a big aspect of underutilization. And then also wiring in rules through computerized physician order entry templates so that they don't forget neglected tests. A great example would be people don't order the anticyclic citrullinated peptide test for rheumatoid arthritis when they should order it every single time they order just the rheumatoid factor. And so you just put it in the order set and make a panel and make it easy for them to order it. So that's what we're doing for that. The interventions for under and overutilization actually overlap. If we're sending you a friend, we might as well send you a person who's going to get you to order the right test. Also, every time you order the wrong test, you're underutilizing the right test. So the overutilization and underutilization overlap a lot. Any other questions for me? All right, I'll stay. Oh, go ahead.
Yes,
Yeah.
thanks. Ludwig Albornoz from Cali, Colombia, Fundación Valle de Lili. I congratulate you, not only a smart presentation, but I enjoyed it thoroughly.
Thank
Question
you.
is, on genetic testing, any concerns regarding the fact that those reports come back with just today's photograph, but they change over time, and how to go back to the patient as time goes by and knowledge is garnered?
Yeah, it's a big problem. I mean, that's why we use the lab genetic counselors. It's up to the geneticist to either repeat testing or reinterrogate the exome. In fact, people are just going to order the exome again. This idea that you're going to get a whole genome and never get it again is, of course, ridiculous because the technology keeps getting better, and labs don't even agree now on their analysis. So that you have to try to put in systems where the patients come back and get reinterrogated. And those systems are very in their infancy now, and in general is a big risk for the patient. So you're actually pointing out a big gap in healthcare that has to be overcome and largely has not. Jane, you're going to talk a little bit about genetics though, right? Yes, and then you can re-ask the question to someone who knows. Okay, thank you. Yeah.
My boss, Mike Astian, second best friend at work, gave a great introduction to utilization, and my role in this session is to go into a little bit more detail and share some specific examples of how we put that into practice. Just, can I get a show of hands? How many people at your institution are kind of charged with this work, who are working on utilization management where you are? Great. So I find this to be very cathartic. So you probably know just as much as me how hard this work is, and this isn't rocket science. So we're just going to do a little commiserating. None of this happens overnight. It takes time. So that is... my disclosure is I should be famous, but that is actually Mike Astian on that photo. I wasn't there that day, so I'm showing it to you because I can. Okay. Seattle Children's, just to give you a little bit of context for these interventions, the things I'm going to talk about might be pediatric specific in terms of the test, but how we made the changes are not. So we are a tertiary care center up in the Pacific Northwest. We have about 250, 280 beds, and we're rapidly growing our patient population. We process about 1,000 test requisitions a day, so we're not a large operation compared to some of the major adult centers in that way. So some of the things you might have to adjust a little bit for your own local example. So these are the cases I'm going to talk about and how we got through. I'm going to talk about trial and error and why it's important to go back and try different things when assessing any one given intervention. We'll talk about provider feedback, report carding, And the thing we highlight there is not to call it report cards, because providers hate that. So there's a lot of other words you can use. Semantics matter a lot. And we'll talk about gaining consensus. And I think to answer one of the questions that was asked about underutilization, that's really a key driver, is to really partner with your providers. For example, right now I'm working with our endocrinologists because they saw a gap in getting the right test for patients who present with hypoglycemia. So there's a big workup you should do to assess if it's an error of inborn metabolism, or what the cause of the hypoglycemia is, and it has to be ordered at the time of the crisis many times. And so we're partnering to make sure that the right tests get ordered when patients present in that way. So I think that's an example of how to help with underutilization. Although from a presentation standpoint, it's hard to get that data, as he referenced, to talk about it in a bigger picture context. We'll talk about obsolescence. Mike mentioned a lot of tests that should just be taken off the menu, and I'll give an example of that. And then we'll close with case review. So I'm obsessed with the tool SBAR. Do you all use that in your institution? So this is a communication tool, situation background assessment recommendation, and it's really, I find it really helpful for all kinds of conversations with my husband at home. I just walk in the door, the situation is, it's been a long day, I need some dinner. Background is, I work with Mike Astian. Assessment is, I'm extremely hungry and the risk is high. Recommendation is, dinner should be ready very soon. So that's just an example of how to quickly get the information that you need out without starting with these long diatribes. So with that, you've probably read and you know about the difference between 25-hydroxyvitamin D and 1,25-dihydroxyvitamin D, and how they are not the same test, actually. But it's very confusing. We don't make it easy for providers in the electronic ordering system. And so this is a story which is hard for me to tell because it took several years, and you know, it was kind of painful to go through because it's a very clear problem. And so I think this is an example of just you got to persevere. This job is not for the weak. And in the end, you will get there, and hopefully you can find some friends along the way. So we started with the simple intervention, which was just a letter. Providers ordered the test. We identified it in our electronic medical system with a flag that says UM at the end. And so our send-outs team identified the test, and then they sent this letter to the provider through an email. And if the provider responded, they just did whatever the provider said. So if the provider said, send it, we sent it. If the provider said, oh my gosh, that's the wrong test, we changed it. And it was surprisingly easy to do. This worked for a very long time. We did it for, in the first, I don't know how many, 8 months is that. And we saw very quickly that 60% of the orders were able to be changed simply by sending the email and providers responding. Now, this is one of my disclaimers. Some providers don't respond to email, and your institution might be more or less email friendly, so you might have to modify the intervention based on your culture. But our providers responded quite quickly, and we had a rule that if they didn't respond within a certain amount of time, we would just send it out and then hope that they saw the email and were just too embarrassed to say anything. And so this worked very well. Meanwhile, this is 2012. We're going around giving talks about utilization, talking about the electronic medical record and using IT rules. And it became quickly very embarrassing to talk about how we're sending a letter and not using more sophisticated methods. So we tried really hard to partner with our IT system. How many of you love working with your IT departments? Anyone? How many of you wish you could partner with your IT system better? Let's ask it that way. So it's hard. Yes, it is hard. Can I get a little commiseration here? Lots of bright lights are in my face. So I think we really wanted to do something more more sophisticated, more elegant, using IT interventions, but it's hard. It's hard to get on that list. It's a very long list that IT systems have to deal with, and it can have unintentional effects. But first, because it's so depressing to think about that, I just want to show you some nice things that providers said. They are nice. They are nice, and they make me feel better sometimes. So these are strategically placed in my office and in my room, and every time my husband says something, I say, you know what, look, people like me. So you're welcome. So the next thing we learned pretty quickly was to privilege. So this was an example that Dr. Astian gave. So one of our provider groups responded pretty quickly as soon as they started getting the letters, and they didn't want those letters. Can you guess who they were? The endocrinologists. Yeah, they didn't want our letters anymore, and they have a lot of opinions. And so we privileged them. We said, you know what, you are right, Dr. Endocrinologist. You don't need this email. So we put a list up of all the providers who should not get the email, and that was also managed by the frontline staff. So a year later, we got on the docket to make an IT intervention, and I did a lot of homework during this time. I talked to a lot of my friends at other children's hospitals and adult systems as well, because this is not a pediatric-specific problem, and I got a lot of different ideas of what worked at different places. One of my colleagues told me that they changed the name. They changed the name of the tests to reflect, to make it easier, that you're not just looking at a number, 125 and 25, but you're relating more to the name of the test and what it is supposed to measure. I even went and had meetings with our providers to see what would resonate with them and what they thought the name should be. And so we landed on vitamin D bone disease, vitamin D renal disease, which is the same, that's 125, and then vitamin D nutritional status. And then also, meanwhile, we were designing a pop-up. This is literally the exact language from my colleague at Nationwide Children's. And it says, do not order this test. That's the first line, if you can't read because it's small. Do not order it. And then it gives you information about what to order. And this is where things got a little embarrassing for me because it didn't work. It didn't work. The name change, actually, we got an increase in orders. And the yellow is highlighting, once I realized that it wasn't working, we put back in our letter intervention for the months of February and March. So it didn't work, and it turns out all the bone doctors, the orthopedists, started ordering when they weren't, because they saw vitamin D bone disease. They're like, that's my test. I'm a bone doctor. And then all the nephrologists started ordering the renal disease one, because they were thinking that it was the test for them when it was actually for the patient. So that didn't work. The pop-up also did not work, and I think we all know why. Has pop-ups worked for you, anyone? No one is raising their hand. Pop-ups generally don't work because people want to ignore them. It's like a competition almost. How quick can they get it all done? Because they have lots of things to do and they don't want to read the pop-up. So we went back to the drawing board and then we came up with the final solution, which was just to hide it. We just took it out. You can't search for it, and it lives within the endocrinologists and the nephrologists' power plans, in their specific power plan. So if a resident tried to search for vitamin D, you just don't see it anymore. And that was 3 years. So I'm hoping you can learn from our long story. So the next situation is daily testing for inpatients, and this is for CBC-DIFFS, specifically at our institution. Actually, it's not even just daily, it's just the fact of ordering a CBC-DIFF when really all you need is a CBC. In pediatrics and in our institution specifically, we have a very high rate of having to do manual CBC-DIFFs because we have a lot of specific rules. So when a CBC-DIFF is performed, I don't know, it's something like 60 to 70% have to be manually reviewed in our institution, which is a lot. It's very time consuming and it slows down the stat testing which is needed for the rest of the patients. So our goal was to identify if there were any CBC-DIFFS which were unnecessary and instead could be replaced with a CBC. And this work was really led by our informaticist fellow at the time and now a faculty member at the University of Washington, Dr. Patrick Mathias. He also has a poster today. I think he'll be there at like 12:30 to 1:30 that's talking about this work as well. So if you want more details, you can go there. So first we looked at where the testing was coming from to see if there were any specific units that we could target. Now what you're looking at here, all the different colors represent a unit, but the biggest color, the light blue, are just the ad hoc orders. So those are not associated with a power plan, which means the simple solution of just targeting all the power plans wasn't going to work necessarily. But the big orange group, which is the next biggest group in the morning there, is from the CICU. And that's the cardiac ICU. And those patients likely don't need daily CBCs and CBC-DIFFS. And so this is where we instituted provider feedback. And we worked with the fellows there in the ICU. So this was a true collaboration with the clinicians. We worked together to see how the data should be presented that would be meaningful to them, and we didn't call it a report card. And I think those are the big learning points there for us. And what they see now, every day they can go in, they can choose a test on this dashboard. I'm not smart enough for this. So you can choose a test on the dashboard, and then every circle represents a patient, and the darker the circle is how long the patient has been in the unit, and then the number of CBC-DIFFS that they're getting per day is on the y-axis, and then those are weeks of blocks. So they can see, are there outliers, or is their rate actually too many CBC-DIFFS? And then monitoring the order of CBCs as well, just by changing that menu at the top. And so that has worked really well. So that big drop in the orange line is the CBC-DIFFS coming from the CICU, and the other ICUs, the Pediatric ICU and the NICU, are the purple and gray lines, and they didn't have the intervention, so they stayed relatively stable. So we reduced the proportion of CBC-DIFFS to CBCs by 50% by working with the provider feedback. Okay, so the third example is another example of partnering with a division specifically to get the right order set in place. And this is for endometrial antibodies. This one is actually a little bit more nuanced because EMA, many of you probably use, it's not the wrong test, it's not quackery, it is a send out, it is expensive, and there are newer technologies coming out. And so this was an example where we just partnered, we looked at the new guidelines that came out in 2013 from the gastroenterologists, and we tried to reduce the EMAs and eventually replace it with a test that we were able to perform in-house, a more automated version, the deaminated gliadin antibodies. So this was another example of meeting with the department over several years, but I'll just abbreviate it and make it look really easy here. So just as a reminder, the endometrial antibody assay is very manual, it's subjective, and interestingly, it actually measures the same thing as TTG, tissue transglutaminase. So it's measuring the antibodies to TTG. It's just called EMA because that's the tissue that's used in the IFA. And it's from baby monkey esophaguses. So think about that. The automated TTG is human tissue transglutaminase. And the big reason why people use EMA is to confirm the TTG. But you're confirming the test you're confirming a sensitive screening test, TTG, with a less sensitive, more specific, but only because it's less sensitive, test that's measuring the same thing. So what we did was we worked together, got consensus with the providers. They agreed to not order it, and so we gave them a period of time where we just reminded them when they did order it that it's going to be phased out and replaced with these other confirmatory tests, the deamidated gliadin peptide. And then we removed it. And so this is what it looks like when you remove it. There's nothing there, they search for it and they don't order it, and we did not hear a single thing afterwards. It's been a year now. No, yes, it's been a year. And we've not had any questions for it. It doesn't need to be privileged because they just don't need this test. So now we have, I should mention, the biggest thing with this was when we removed it, you still get orders from the outside. And so one thing that we didn't do right away, which was tell our staff, forgot to tell our staff that we were no longer offering this test. And so when providers couldn't find it to order it, they just didn't order it. But when providers bring their patient to be drawn, because we're good pediatric phlebotomists with a paper requisition, our poor staff was searching all over for this test, which didn't exist. It wasn't in the test catalog, it wasn't orderable, and it actually caused quite a bit of confusion. And so we made a page, and of course I went out and apologized, which I'm also very good at, and I could give a lecture on that as well if you're interested. But the point is you have to remember all the people who were involved, which we did learn our lesson, and that is part of this story, the MTHFR obsolescence story. So MTHFR variant sequencing is pretty much not necessary. There's it's very controversial, but there's lots of evidence that it doesn't mean anything clinically, and it actually causes a lot of unnecessary worry and referrals for our specialty teams. And so we worked to remove it. We said it was no longer needed, it's obsolete. We did a bunch of education, took it out of our test menu, and we told the staff this time, and we gave them resources too, because we knew it would be slightly controversial. So the test catalog says who they can call, and that's the lab GC. So if there's any questions from a provider who wants this test that we no longer offer, it's not on the menu, you can't get it here, you can call a lab GC to understand more about why it is no longer needed. So we got our consensus. In general, if there's a test that you think should be obsolete, like IgG allergy because it's quackery, or reverse T3 because it's not clinically indicated, it's best if you can find a test that is indicated and that would help them and to replace in that way. But some tests like this one, MTHFR, doesn't really have an equivalent because it's just screening for a risk that you might have that may or may not mean anything. So there's really not a replacement test in this example. You write it up in a policy so you have something to hand to someone, and then you tell all your staff. Those are basically the four things that you need to do. And this is what it looks like if you Google it, if you search for it in our test catalog. We have a big note. This is seattlechildrenslab.testcatalog.org. If you search for MTHFR, you get this note that says we no longer offer it, you can't have it, and there's no evidence for this. And so that's actually surprisingly effective. And our geneticists thanked us because they really didn't want to deal with having to have the patients who had these variants that may or may not mean anything. So that brings us to the last case, which is case review. So this is what Dr. Asien was talking about when we review expensive genetic tests, and actually all genetic tests, because not only are they costly, but they are error-prone. There's redundancy in test orders that can't be detected by IT rules because of the rapidly changing environment. So a test 1 week might include 7 genes, and the next week that same test is a panel of 30. The technology is changing, and it's just too much for anyone to keep on top of. So we have 4 lab genetic counselors now whose job it is to see these orders up front and make sure it's the right one. not only is it necessary, but it's the right one because we detect a lot of errors. And this is just, I think, a really clear example that shows how it can be beneficial and how we partner really well with providers to get the right test. So in this case, a 12-year-old was admitted for hypoglycemia secondary to hyperinsulinism and associated seizures. So he was admitted right away. He was seen by lots of team members, including endocrinology consults, and they were trying to differentiate if it was caused by a genetic etiology or an insulinoma. And so they requested concurrent testing of 8 genes in the inpatient setting, including a gene called GLUT1, GLUT1, which is glucose transporter type 1. And this error was caught on LabGC review. Now, if we had just done a chart review by someone like me, for example, I might not have caught this because the provider said she wanted GLUT1 in her notes. She ordered GLUT1. So the patient is sick. It doesn't seem unreasonable to differentiate that, so I would have approved it. But the LabGC is like, GLUT1, that's the wrong disease. That's de vivo disease. This provider probably meant GLUD1. It's just one letter. It's a D, not a T. They even sound the same. Glutamate dehydrogenase 1 is a gene that's associated with hyperinsulinemic hypoglycemia, and that's the gene the provider wanted. But for lots of reasons, you just type the wrong thing, you order the wrong thing, it happens. She didn't go to work that day saying, I'm going to do the wrong thing. But our LabGCs were able to help her have a relatively easy conversation to point out the mistake, correct it, and get the right gene ordered. Now, the fact that there were 8 genes ordered in the inpatient setting is a different issue, and we have made some steps there. Incidentally, all these genes were negative. So based on that, we like to not focus on the fact that we're reviewing because of cost, because actually the errors, I think, make more impact to patients, especially in the inpatient setting. So of the reasons that we're modifying the order, it's 10% is because it's the wrong order. It's GLUT1 instead of GLUD1, or it's just the wrong order. We're canceling 27%. 27% of the tests we cancel are because they're the wrong order, and then no genetic testing is indicated at all. So this is how we like to focus on that. We recently, this is actually now, it took a year, so it actually should be said 2016. It's now searchable in PubMed. This is Dr. Patrick Mathias's work with us on looking at errors by diagnostic errors in the genetic testing realm by specialty and order setting. So it's not surprising that geneticists, so we have geneticists on the top left and non-geneticists on the right, and that's a percent error of, I don't know how many, 1,500 tests that we reviewed and the accompanied chart review. So 2% of errors are attributed to geneticists with a higher rate by non-geneticists. And then similarly, there's a higher rate of error in the inpatient setting, and this is likely due to a combination of factors, including that trainees are involved and including that consultants aren't the ones who are placing the order, and that it's often just not indicated in the inpatient setting. So, how am I doing on time? Okay. One question that we had struggled with for a long time was how are we going to move this process in detecting the wrong test before the patient gets drawn? Because many times a sample will arrive in the lab, we determine the test is not necessary, but the provider has already established expectations with the family and the blood is right there, and we don't like to waste blood on kids. So sometimes we would just send the test out knowing that it wasn't the best thing to do, but that half the work had already been done. So we moved our ordering process to before collection by building what we call a communication order in our system, which is Cerner. And so providers who want to order a genetic test and who want to go down the authorization path because that's required by our hospital, they order this communication order, they say what the test is that they want to order and why they want to order it, and then the LabGC reviews it at that point helps them package everything up for pre-auth to submit to the insurance pre-authorization department, and then watches again for when the order comes in with the sample, because there's still errors even after you do all the work up front. There's still errors when the test actually gets ordered. So we were able to pilot this with just the geneticists for 3 months. We saved a lot of time, we improved a lot of efficiency, and got the review step before the patient was actually collected. And ultimately, this has had pretty serious financial implications for our institution. It's why we're able to justify having a staff of 4 genetic counselors, and we're providing value to the patients in connecting these errors. So in the past 4.5 years, can't believe it's been that long, we've seen almost $6 million. This is actual dollars of what tests cost. And then we're saving almost $1 million in that time period. The amount that we save per test is now at about $280 per test request that we review. Of course, that number varies. If you decide to use a higher threshold, if you're only going to look at things $1,000 and up, you're going to save more per test. But as you decrease that threshold, that number goes down, but still provides significant value. So to see the whole step through, we get the right test order, but now we want to make sure that the provider actually gets the result. And not just the ordering provider, but the intended provider. So all these cases are tracked in the database with the provider who we know is behind the order. So it's not the fellow, it's not the resident, or the proxy who happens to actually place the order, but it's the geneticist who saw the family, made the request. We send them a note when the result gets back. Because these take so long, people often forget. It's hard to find where they are in the medical record, too, because they are buried in the scanned document section. So we want to make sure that providers are getting the result. And we want to make sure that they are seeing the value as well. So we designed a survey that providers take annually, and we have about a 50 to 60% response rate, which is not terrible. And so what we did was we asked providers how they feel about getting the results. The scale is over here. It's kind of hard to read, but the light color is not at all satisfied, and the almost darkest color is the most satisfied, and then the very darkest color is they chose that question did not apply to them. So we asked how they felt about getting the result notification, if that was something that was useful. You can see the majority felt very satisfied. Only a small percentage felt neutral about it. We asked how they felt about the support from our lab GCs, if they liked when we told them how much the test cost, and if they thought the process was useful, having genetic counselors. And then we asked the same thing regarding pre-authorization, if they were involved in that. And so overwhelmingly, it's a positive response from the providers who responded. And they also give very good feedback, not just, "You're so great, we love you," which is always nice, but they were the ones who asked if they could have the cost of the test several years ago. They asked if they could get result notification. So we're modifying our process based on the feedback we get from them. And hopefully we'll continue to provide value and grow our partnership with the clinicians in that way. So we like data, and we think it's important that we're monitoring these interventions, not just for the genetic test, but for all the tests. So we have a dashboard that we review with Dr. Astian on a regular basis to show the volumes, the work that we're doing, and the rates of modification. So I think we've said enough here today, so we'd like to just take the opportunity, both Mike and I can just answer any questions or discuss informally if the plenary session's happening and you need to go. You know where to find us. Thank you.
Time for a few questions. I know it's right on the half hour here. Any questions? I have one, Mike. You guys have resources, so and clinical chemists and so forth. But what would be a recommendation for smaller institutions? Just to get started. Is there an IT solution that is on the horizon? You know, where are the minor and major gaps to get stuff off the ground for less sort of equipped healthcare systems?
So for those that are resource constrained, Jane? I always do that. I like Jane to answer the question because she's smarter. Actually, for resource constrained place, I think the first thing to do is to still have a program, but just set the thresholds for review high enough that you're not killing yourself with cases. You can't set the threshold for genetic case review at $200. When we started our program, we had no resources. We set the threshold at $3,000 to review a genetic case. So even if you're reviewing 3 a week and one's a duplicate, you save $3,000 a week, which is $150,000 a year. So you just set the thresholds for the time you have. The other thing I would say is see if you can borrow a genetic counselor from the for genetics from the clinic to just review 1 or 2 cases a week. You know, there's a 1/3 chance you're going to modify it in a direction that's both medically favorable for the patient and financially favorable for either the patient or the lab. So that's a good way to think about it, is to use thresholding. Do you have any other recommendations, Jane, for resource-constrained places?
When asking about resources, I always think about the IT, and I think it's okay to use the manual interventions just as a proof of concept. So the emails, the things that don't take a lot of IT resources that you can just get off the ground and pilot, you shouldn't be afraid to do that, even though it's embarrassing.
It's pretty cheap to ban labs too. You know, if you get a list of labs that are practicing quackery in the reference lab, you can that doesn't cost anything to just take them off your reference lab list or specifically ban them. That can save money and protect the patient as well.
All right, thanks again, guys. Appreciate it.
Thank you.